honor to have you join us today, and I thank our Silver Circle, Ms. Nalini Sashidhar, for making this possible. A little about Dr. Naresh Bhatt, who is the Chief of Gastroenterology and Hepatology at CMI Bangalore and past President of the Indian Society of Gastroenterologists. Dr. Naresh Bhatt is MBBS from St. John's Medical College, Bangalore in 1980 and General Medicine from PGI.
Rama, can you unmute yourself? Sorry.
Okay. So where did you lose me? A little about Dr. Naresh Bhatt. Hello.
Yes, that's where we lost you, Rama.
Okay. Dr. Naresh Bhatt has done his MBBS from St. John's Medical College, Bangalore in 1980 and MD in General Medicine from PGI. Later in 1985, he completed his DM in Gastroenterology from PGI. He also completed a fellowship in therapeutic endoscopy and short-term fellowship in advanced imaging at Yokohama, Japan. With over 30 years of experience, Dr. Bhatt's core strengths are clinical gastroenterology and advanced endoscopy. Without further ado, I invite Dr. Bhatt to now take over. Thank you, Dr. Bhatt.
Hi, good evening, and thank you, Dr. Rama, and thank you, Deepthi, for having me over this evening. I note that there are about 70 or over 70 participants listening in, and I think I eminently fit into your group with my gray or more than gray, it's more silvery white hair.
You're most welcome to join us.
All right. When Nalini asked me some time back whether I would be happy speaking to you all, I said most certainly. But the format that I really am comfortable with is basically answering questions from the audience, and I look forward to that kind of interaction. So I'll set the ball rolling, talking about something which I think is important for most of us in this group. And I'll start off with something which I call polypharmacy. Now, what is polypharmacy? If we look at our own prescriptions that we carry home, and we find that all of us are on multiple drugs. And if there are more than 5 medications in your prescription, you know that you are a victim of polypharmacy. Why do I use this harsh word of victim? You'll see in a few minutes. Because most of the time, when you're younger, if you had a headache or a fever, you were given one medication. Maybe it was a tablet of paracetamol or a painkiller or whatever. But as we grew older, we found that we didn't go home with just one drug. We went home with several drugs. And the reasons for this are many. One, of course, is that we have many diseases that we have as we go old. You may be having blood pressure, you may be having diabetes, someone may be having a prostatic problem, someone may be having a problem with sleep, someone may be having osteoporosis, and someone may be having Parkinson's, and so on and so forth. The end result is that you are going home with 5, 6, 7 drugs to take. The problems with this, to a large extent, also lies with the doctors who prescribe these drugs. Now, typically, if I see an older person in my outpatient, I find that before me, he has gone to the cardiologist, he perhaps has gone to the neurologist, and he's also seeing his GP down the street, and then finally comes to me saying, I have got problems, and what do I intend doing with it? Now, this is, I think, a very crucial step, because the more doctors you see, everyone thinks it is his divine right to write out a drug, and he says the patient is going to go back home unsatisfied if I don't write a drug. And so everyone adds maybe 1 or 2 drugs to this. And then we have the people complaining, I eat less food than the number of drugs that I'm taking. And it's really not funny. And what happens in the process? In fact, they did a study on about 1,280 patients who had this kind of what we call polypharmacy. And they found that, interestingly, this is about...
Disturbing the session.
About 30% of people were having a polypharmacy, and about 16% of the medications were highly inappropriate. And worse, up to 9% of drugs were duplicates. Duplicates meaning, suppose you're using a drug called a beta blocker, the cardiologist has given you a beta blocker, the GP has added another beta blocker, or vice versa. So what does it result in? One, of course, it results in an enormous number of drugs that we're taking. 2, it results in excessive costs. And then, worse, it leads to various kind of adverse interaction between drugs. For example, there was this patient who was taking some tablet for his acidity. He was taking what we call a PPI, or a drug like omeprazole. All of you know of omeprazole. He was taking a tablet, omeprazole or Omez, or things that you're more familiar with. And then a few weeks later, this gentleman falls down and fractures his hip. Seems to be nothing out of the ordinary. But when we really looked at what he was taking, we also found that this gentleman was taking a tablet for his sleep disorder from his GP for quite some time. And he was given this Omez tablet as well by another doctor, quite unaware that he was taking diazepam. So you may ask, so what? What's the connection between that and the fracture? But we do know that these drugs can interact. And what the PPI or the Omez does, that it increases the level of the sleeping medicine, making this old man drowsy and resulting in a fall and breaking his hip. Now, this is just an example of when you're using just 2 medications. So imagine a situation when you are taking so many medications. And the general rule is that if there are more than 4 medications, there is a 10% chance that there is a drug-drug interaction going on. If there are 5, it's up to about 25%. So if you actually go and audit your own prescriptions, or if a doctor audits his prescriptions that the patient is going back, you'll find that it's quite likely that one drug is adversely affecting the effect of the others. For example, you may say, okay, I have got acidity. Oh, let me take something so that I feel better. You take a drug like Omez, right? And then after 2 days, you say, I'm not better. You go and ask someone else, oh, you're taking Omez, why don't you take another drug called Sucrafin? Very common mistake. About 30% of the patients who see me have this kind of combination. What happens? Omes does not act because sucrafil prevents it from acting, and sucrafil doesn't act because omes prevents it from acting. Almost sounds like one of Ajit's dialogues, no? But oxygen usko marne nahi dega, or something else usko jeene nahi dega, or whatever. So this is exactly what happens in day-to-day practice. So polypharmacy, as far as I'm concerned, is a huge problem for all of us, especially for the older population. A lot of patients come to us with saying that, I've got a urinary problem, and not realizing that some of the medicines that he's taking itself is causing the urinary problem. And so what happens in this cascade is you're on two medications, one is causing a side effect, so a third drug gets added. Now, because that has a side effect, a fourth one gets added. So it is important for us to find out a way beyond polypharmacy, beyond getting stuck in this rut of adverse reactions. I would accept that the primary responsibility is that of the doctor. There's no doubt about it. And hence, you must sit with your doctor and ask him, are you sure that these drugs are not interacting? You must ask your doctor that, and he must come up with a satisfactory answer by checking up. I mean, no one is an encyclopedia anyway, so you can check. And in fact, some hospitals have a software on their computer which tells you if there's a drug-drug interaction and prevents you from prescribing that, but not everyone has access to that. But what can you as a patient do is have a record of what you're taking. When you go to see a doctor, have a record of what medications you're taking, whoever is prescribed, whether it's a cardiologist, whether it's a GP, whether it's your friendly neighbor who's a doctor, or your uncle or a nephew who's a doctor in the US or London or whatever it is. That entire list has to be there. And make sure that there is no drug interaction, and ask your doctor, is it possible that I can remove two of these drugs, and instead of two drugs, can I use one drug which will do both the jobs? I think that is intelligent prescribing, and that is what is important. And I think as patients, you do have a right to expect that we avoid polypharmacy as much as possible. It's not that it's always possible. Sometimes you have to use multiple drugs, but it's likely that you can substitute two drugs with just one drug. There's no point in taking 2 vitamins or 3 vitamins, but minimize those. So appropriate drug only when it is required. To minimize drug, look for drug-drug interactions, and make sure all your doctors are on the same page, or better still, have one of the doctors, whoever it is. It may be your GP who's maybe very knowledgeable and who can do it, or maybe it's your specialist who's knowledgeable and who can do it, who can rationalize these drug prescriptions and make it appropriate and, more importantly, safe for you. I think I'll stop here and maybe take on some questions. Otherwise, we can go on to some other areas. Yes, Dr. Rama.
Let me take this from here. I hope you can hear me.
Yeah, I can hear you, Deepti.
Okay, great. I'll just put it on gallery view so everyone can see. Do you want to cover anything on digestive health, doctor, before we move forward, or would you like to answer questions right now?
See, the problem is digestive health is such a large topic, and I'm not sure whether it will interest everyone. So I'd rather take on questions and maybe we can sort of talk around it. There are several issues that I can speak about, but let's make it useful to the people listening. And if there's some time, then I'll deal with the general issues as well.
Okay. So I'll just first take a couple of questions that have come in here and then address questions that have been emailed to me as well. Since we're on the topic of drugs, Arun Malhotra asks, is there a qualitative difference between generic and high-profile drugs?
Okay, we don't use the word high-profile drugs, but yes, generics and the innovator or the ones that have come out with the research molecule, the first thing, it's a bigger problem actually in the West than in India. But I think by and large, generics are as good as the innovator drug in almost most cases. As a clinician, I'm sometimes concerned about using drugs from unknown pharmaceutical companies because unfortunately we don't have a great regulatory system in place. So if I would choose a generic drug from 4-5 brands, and something that is less expensive is something that I'm quite happy prescribing. I don't insist that it has to be the number one brand. No, it's not necessarily so, especially if it's expensive. But certain times when it comes to life-saving antibiotics, life-saving drugs, I think we do not want to take a chance, and that's where we would sort of make an exception. But generics otherwise are reasonably safe, a good idea to use because it brings down costs tremendously.
Okay. And speaking about polypharmacy, Uma Pai has a question. She says, when you are comorbid, what next? Do we have to take a different drug or how do we manage? Now, Uma Pai is a cancer survivor.
Fair.
How do you
I
manage?
appreciate that when you have multiple problems, you obviously have to take multiple drugs. But see, suppose you've got blood pressure and diabetes, sometimes you don't need to have 3 drugs for your blood pressure. You can rationalize and make it 1 drug for the blood pressure, or maybe 2 in case things are not working out. Adjust the dosages, use each drug to its optimum level, rather than khichdi of a little of this, a little of that, a little of that, and let's try and cut your blood pressure. That's perhaps bad strategy. And this, unfortunately, what happens in practice is that everyone has his own khichdi. So a cardiac khichdi, a diabetic khichdi, maybe a GI khichdi, so you may have to use, for example, a patient with migraine and a patient with hypertension can manage with the same beta blocker. There's no need to take a beta blocker here and a topiramate here or something else. So that intelligent prescription, I think someone has to take on the role. One doctor whom you see has to take on that role.
Okay, thank you, doctor.
Thank you, doctor. So this generic medicine, what we nowadays learn from this Jan Aushadhalaya, what the central government is proposing. So you think they're okay as a substitute for our other medicine? What is prescribed?
I can't vouch for it. See, why there are, if you ask me, say there may be a drug, an originator drug may be 12 rupees a tablet, but there are pharmaceutical companies may bring out the same at 6 rupees or 7 rupees, right? But then there are fly-by-night operators who work in small, garages and sheds and make out tablets and, get a tender passed by the government. We don't know the quality, and that is where the problem comes. So I can't give you a straight answer that all generics are safe or good, but I think by and large, you have to trust generics to a reasonable extent. I won't say that all generics are bad. Just go for the most expensive drug. No, I don't think that's the message.
Okay. Before we address questions on tummy and bowel syndrome and things like that, I'm just going to cover questions related to medicines first. Panathpur Murthy says, do vitamin supplements also interact with BP and diabetic medication?
Not really. Not really. See, most vitamins, what vitamins we need in very small amounts, right? So all of us taking vitamin supplements perhaps are kind of overdoing a lot of things. So the good thing about most of the vitamin, at least the vitamin B, is that doesn't stay in the system for too long. You take it in the morning, by the end of the day, you've peed it out of your system. But there are some vitamins, now vitamin A, vitamin D, vitamin E, these get stored in our body. And so these can interact, and especially we've noticed that of late, there's such a hype about vitamin D deficiency that everyone is popping in vitamin D left, right, and center. One must understand that vitamin D is not a vitamin, all right? It's not a vitamin. It is a hormone. And it was labeled a hormone 40 years ago when I was a student. Yet it's doled out like a vitamin that everyone feels it comfortable to take it as and when she feels, or is prescribed so much that we find patients, because it stays in the body, we find patients who get toxicity or side effects. And one of the feared side effects is a swelling of the brain, which can kill. So you must be careful with what you take. The vitamin B complex generally does not interact with your medicines with diabetes and blood pressure. So if someone who's got diabetes, blood pressure, they certainly should take a vitamin. It's not even necessary to take it every day. Even if you take it twice a week or so, it's, I think, good enough to meet your requirements.
Great advice, Doctor.
Yeah.
Dr. Rama Ramchandran asks, typically for a person with diabetes and hypertension, what could be the ideal number of drugs to be taken?
No, there's nothing. Ideal is 5 or less, but that's not really possible. Not really possible. So what we need to do is look at the, now I see now about, if you look, I'm sure all of you have heard about uric acid. And if you look at your reports, you'll find uric acid high. And every single patient who's got a high uric acid has one drug called, allopurinol or febuxostat or something added to it. But 99% of the lay population, and perhaps, unfortunately, 95% of the doctors are not aware that we don't need to bring down this uric acid just because it is high. We need to bring it down only if someone has got symptoms of gout, that is, he's got some joint pains which we can attribute to gout, or he's got uric acid stones in his kidney. Otherwise, you don't treat a value of uric acid. So these kind of things which we need to take care. We can't say that cut your drugs down to 6, cut it down to 7 or something. It may not be possible, but minimize it as much as possible with appropriate, prescription practice. So whatever can be chopped off from the prescription, I do. What has to be retained, what is essential for the patient, we continue to take. For example, let me talk about aspirin. Can I have a show of hands? How many of you take aspirin here in this audience? Except Deepthi, I'm sure most of them would be. Right. Now, the thing is that why are we giving aspirin? Now, everyone is so aspirin is a wonderful drug. It prevents heart attacks and so on and so forth. Right. That point is correct. But aspirin is a good drug only if someone has a significant risk for heart disease or stroke. Right? Now, if I give aspirin to someone with a significant risk, that means he's obese, he's had a previous heart disease, he's a smoker, and so on and so forth. Yes, that he's got a risk of getting a heart disease in the next 5 years. His risk is about 15%. He will benefit from aspirin. Right? So, in medical terms, we have something called number needed to treat. So, if I treat 4 patients, I will benefit 1. It's not 100% protection. Please remember that. 1 in 4 of those patients will have a reduction in his stroke or heart attack risk. On the other hand, if you take someone who's got no problems and just swallowing aspirin, just because someone said it's good, the number needed to treat is 82. That means for every 82 patients you give aspirin, you will have a reduction in your risk for a heart attack. Now, as against that, we have something called number needed to harm. You know that aspirin can harm as well. And so in a person who doesn't have much of a risk of getting a heart attack, you give aspirin, the number needed to harm is 8. That means 1 in 8 will get a serious ulcer or an ulcer-related bleed. Number needed to, harm is so high, 1 in 8, as number needed to treat is 82. What is the risk benefit? The risk of getting a problem is much higher than the benefit. So this is something that we need to think about and understand. And then you say, no, aspirin is essential. But is it essential for you? So if it's not, get it out of the prescription. So that everyone needs all these drugs, I think is a wrong concept and should be given up.
Okay, thank you, doctor. Vinita says, so she has a brother who's 64 and he's mentally challenged, and he's been given a whole range of medicines. One is Ecosprin 75, Levpil 500 XR, Neurobion, Thyronorm 100, Envis 5 mg, and Eliwell 50 mg. Are these compatible? Would you know offhand if they are compatible?
Now the question is, why is he on Ecosprin? I don't know. Levipil, perhaps we may be having a seizure. Thyronorm is for his thyroid, obviously. He may be having blood pressure. But I'm not sure why he's on so much of Eliwell. I'm sure, but the combination of Levipil and Eliwell must be making him drowsy. So I don't know. So it's important to know what is the indication. Why it's not just the drug, but why are we giving it? Is it essential in the first place?
Absolutely.
I think that's really the message that needs to come through.
Okay. I'm just going to go to questions that have come in by members. Bandana has an important question to ask. She says, in a person with autoimmune hepatitis in compensated cirrhosis, is methotrexate 12.5 mg likely to aggravate fibrosis? The person also has SLE, which is well controlled for several years. Should fibroscan be repeated after some years? Is it likely to be sensitive enough to compare with an earlier one? And what is the prognosis expected quality of life in someone with compensated cirrhosis?
Okay, I think this is a very technical question. I don't think it's appropriate for this audience, but let me just tell you that for autoimmune hepatitis, methotrexate is not the most appropriate drug. Methotrexate is bad for someone with liver disease. It can worsen it. 1. 2, or methotrexate is not the most appropriate drug for SLE either. So I think we need to rethink on this prescription. Right?
Doctor, I'm Vandana Malhotra. I'm also a doctor. So please just clarify my doubts. These were my questions.
Yeah, so I'm just telling you that generally we don't use methotrexate as first-line therapy for SLE, nor do we use methotrexate in autoimmune hepatitis at all.
Yep.
So we may need to use different drugs which are safer for the liver.
I've been taking HCQS, which is for 20 years. HCQS.
Or not methotrexate?
No, methotrexate was started, I don't know why, 2 years, 3 years ago to wean me off the steroids for autoimmune hepatitis.
No, I don't think that's an appropriate drug.
Yeah.
And more appropriate drugs would be azathioprine, not methotrexate.
I am allergic to, I can't take. I had a fixed drug reaction to it.
Then we can use something called 6-mercaptopurine, or we have other options, but not methotrexate. Methotrexate has not been shown to be useful in autoimmune hepatitis at all.
Thank you. That was one.
There's another question here, which on the liver, which I see here, is a 62-year-old someone with fatty liver.
Doctor, my questions aren't over. Please, one more. I said, what is the prognosis for compensated cirrhosis?
Prognosis for compensated cirrhosis is very good, provided we take care of the basic cause. That means we don't allow progression of the disease. 2, we recognize complications and treat them energetically and early. The prognosis is good. A lot of our patients with compensated cirrhosis survive for 10 years and 15 years. And so it's good provided you do the right things.
What would those be?
As I said, treat the basic cause. If the hepatitis B, treat the hepatitis B. Hepatitis C, treat the hepatitis C. If it's alcohol related, stop alcohol. If it's autoimmune hepatitis, treat the autoimmune hepatitis properly, whatever.
And fibroscan, does it need to be repeated?
Yes, fibroscan can be repeated once in 3 years to see if there's any progression.
Right. Thank you very much.
Okay. Now, there's someone with fatty liver and says, is it okay to have a fatty liver and what precautions? See, fatty liver is a very common kind of problem. And we see a lot of people who have fatty liver. Not everyone progresses to cirrhosis, but some of them do. And the people who progress are those either who continue to take alcohol, poorly controlled diabetics, patients who are diabetes and obese, and patients who are diabetic, obese, and are taking some drugs which are harmful to the liver. So these are patients who can progress. So fatty liver is not necessarily a very innocuous kind of situation, right? Especially if you have diabetes and you're obese. The chances of progression are quite high, and especially as you're older. So typically what happens, we say someone has been having fatty liver from the age of 50, 55, and suddenly when they at 60, they come to us with full-blown liver disease. So this progression can certainly be preventable. So if you have a fatty liver, you must go and see your doctor and say, can I prevent progression? There are a lot of ways that you can do it, and we must use those modalities to prevent. And one of the best ways is not medication, but exercise and diet.
Okay, doctor, great. I think from here on, we can talk about gut health. It's 6:35. We just have about half an hour to go. So if you can now focus on gut health, and there are a couple of questions that have come in regarding that. So would you like to talk about it a little bit before we proceed?
Now, let them ask the questions. Okay, I'll talk about milk first, which I'm sure milk and wheat are two things which I like to talk about, is that everyone sees advertisements on the TV talking about the good things about milk. And a lot of say this doctor is mad because he says milk is not a great idea for you. And I reiterate that milk is for babies, right? Milk is not for adults. Because if you look at it, I mean, nature, where do you get milk from? Milk is from the breast of some human being or a lady or some animal. So a cow's milk is essentially meant for its calf, right? Here we are as humans, grown up to the age of 70 and still want to drink cow's milk. So it is not designed for that. But what has happened is over millions of years, because people sort of went into dairy farming, nature caused some evolutionary changes that allowed us to digest milk, right? Otherwise, in nature, over the age of 2, 3, 4, our ability to digest milk keeps dropping. So much so that by the age of 10, most of us are not able to digest milk. This is true for most of us who are South Indians, who are East Indians, and West Indians. But if you look at, say, people from Gujarat, Rajasthan, the entire northern belt, or even the Caucasian population, the white population, we find that their ability to digest milk persists even in adulthood. So typically, you find them consuming milk and they're quite happy with it. I have no fight with them at all. But when a South Indian, people who are genetically South Indian try to take milk beyond a certain quantity, they can't handle it. And it leads to symptoms like causes bloating, causes diarrhea, causes gas, and so on. And hence, they should be avoiding milk if they are having symptoms. So if you're having symptoms, maybe a good idea to stop milk. But then they say, Doc, how can I stop milk? It's so important for calcium. I read Femina the other day and they had a big issue and they said calcium comes from milk. It does. But Femina didn't tell you that curd and buttermilk has as much calcium or more calcium and is more nutritious than milk. So you can substitute the milk with curd or buttermilk and live just as healthy. So that myth that milk is essential and is good for everyone is not really true.
Great. And what about wheat, doctor?
Yeah, wheat. Now, this is a great fad that is there. We know that some people in the world, and we know that up to 1% of people in North India and about 0.1% of people in South India are intolerant to wheat and have a fairly serious disease called celiac disease and need to be on a wheat-free diet or a gluten-free diet. Celiac disease causes changes in the gut. It causes malabsorption. It can cause iron deficiency anemia. It can cause weak bones. It can cause liver disease. It can cause infertility, so on and so forth. So if you have celiac disease, you certainly need to avoid wheat. But what has happened now is now there is a current fad of internet medicine, which everyone now believes that whatever his symptoms in the gut, if he stops wheat, I mean, that's a panacea for all ills. Not realizing, yes, you stop wheat if you're a hardcore South Indian. You can get your nutrition from your idlis and dosa and rice and bisi bele bhat and so on. But if you're a North Indian and I ask you to stop wheat, you would curse me for the rest of your life. So we need to be reasonably certain that that step is justified. And if it's not justified, I think we should avoid. So this business of whole scale, avoiding wheat for half the population, I think is wrong and causes a lot of nutritional problems.
Okay, great. Would you like to touch upon irritable bowel syndrome? Somebody here asked for a little information on it.
Okay. Now let me tell you what irritable bowel syndrome is. Now, irritable bowel syndrome is essentially a condition where you have symptoms, you are truly suffering, right? You have symptoms and truly suffering, and they estimate that the quality of life can be quite miserable in these people. But at the same time, you don't have a test to prove the diagnosis. I can't do an endoscopy and tell someone, oh, you got irritable bowel because I can see that diagnosis there. No, all tests are normal in irritable bowel syndrome. It's the same like saying, you have migraine. How does your doctor diagnose migraine? He just listens to you and say you got migraine. A CT scan or an MRI is not going to tell you got migraine. So irritable bowel syndrome is essentially a diagnosis that we make by just listening to the patient. And hence, we have to be very, very certain that we are not missing out important diseases which can have the same symptoms. And that is why, to make a diagnosis of irritable bowel syndrome, we usually say patient must have symptoms for at least 6 months. So if there's anything serious that would have got sort of come up and be recognized. So someone has got long-standing symptoms, we consider irritable bowel as a possibility. And obviously we say he should not have lost weight, he should not have anemia, he should not have very poor appetite, and so on, to make sure that we're not missing out the real diseases. Why does it occur? It's because of a certain sensitivity, an increased sensitivity of the gut. And this can be because of many causes. It can be stress, it can be a previous infection, it can be a previous psychiatric trauma in the past, whatever. Several things can occur, resulting in a hyper reactive gut or a very sensitive gut, which causes symptoms with a lot of things. I always give this example. If I pat someone on the back when they are in a good mood, they smile and say, hi doc, how are you? If I pat someone on the back when he or she is in a foul mood, they would just do that and say, what's wrong with you? Why are you doing that? The pat has not been different. It's the same guy who's patting you on the back, but the way you've reacted is different. That is irritable bowel syndrome. Is the way your gut reacts is a little different, making it unpleasant. So that is what irritable bowel is.
Excellent way of explaining it, doctor. Thank you. Nandini has a couple of questions. She says, speaking of dosa and idli being a staple in the South, does dosa cause acidity? She has a couple more questions. She says, is ready-made curd not a probiotic? What is the best gut cleanser? And do zinc supplements cause acidity?
Okay, one at a time. Zinc supplements don't cause acidity. Two, what commercially available curd or any curd is not considered a probiotic because the regulatory authorities say that probiotic is a drug. So our homemade stuff may have nutritive value, but we don't refer to it as a probiotic. They may have good bacteria, but we don't know in how much. So probiotics are regulated as a drug. So we don't consider these as drugs. So a lot of what is sold in the market, are not really truly probiotics. They're actually just uh, a facade that's created, and I don't think we should use as probiotics. Eat your own homemade curd. That's far more cheaper than these commercially available curd and so on. The third question was about dosa being acidic. I don't
Yeah.
think dosa is really acidic unless you use a lot of ghee or oil with it, or you take some chutney pudi and add a whole lot of oil with it. Otherwise, it doesn't not really acidic in that sense. Because when someone talks of acidity, you really say some heartburn or discomfort here. I think a dosa without too much of oil and ghee, I don't think will cause acidity. There was one more question. I don't know what that was.
Yes. Which is the best gut cleanser?
Okay, gut cleanser. The question is, do we need a gut cleanser? I think we've been brought up with this concept that our gut needs to be sparkling clean all the time, and your parents or your grandparents gave you a liberal dose of castor oil every weekend or once in a month or whatever. That belief that toxins accumulate, you need to get rid of these toxins. So this thing is something that is inbuilt. I don't have a bowel movement, I'm dirty, and I need something to cleanse my gut. I think so. The first point, I think we need to understand that it's not necessary to have a gut cleanse, because you'd be surprised that after taking a gut cleanser, how much poo is still there in the bowel. You ask me because I do colonoscopy day in and day out. So that concept of gut cleanser actually cleanses your mind more than it does a gut. But yes, if you need to have something to help you have a bowel movement, I think a little fiber in your diet, maybe something as simple as a subgol, is not a bad idea.
Okay, speaking of gut cleansing, doctor, I know of people who get an enema done once in 6 months. Are they crazy or is that advisable?
No, I think that should be strictly avoided.
Sorry?
Let me tell you, it should be avoided at all costs,
Okay.
because neither is it scientific nor is it safe. We have patients who have required surgery because they've been given enemas in the hospital, not taken at home. Hospital, given by nurses, we've had them perforate or make holes in the rectum.
My God.
It is not safe. Please don't indulge in this. If you ask me how many times a year that I prescribe an enema in a hospital, I think maybe less than once a year.
Wow.
I think it's really not required. So there are far better ways to get you to have a bowel movement rather than hanging one enema can in and a long rubber tube in your bathroom. I think those days have gone past.
Great. Jaya Kalyan has a question. She says, much of the time I break fast with a huge bowl of fruit, generally papaya. My stomach feels out of sorts. If I have idlis, dosas, porridge for a change, should I be avoiding these at breakfast?
No, see, there's no one size doesn't fit all. We know that. And all of us have got our own taste, or what we can handle, what we can't handle, right? So I think you should stick to what you can handle. I don't think that just because Joe Biden has cereal for breakfast, that Jaya needs to have cereal for breakfast, or just because Rama has uttapam for breakfast, that I need to have uttapam for breakfast. I will eat what I think comfortable with. She will do what she's comfortable with. So there's no rule here, right? But in the same way, let me just allude to this business of fruit. We all eat a lot of fruit, thinking that it's very good for us. And everyone believes that fruits are a great thing to have. not realizing that why do we have fruit? Can anyone just come up with an answer? See, fruit have major reason why we need to eat fruit is because it's a good source of vitamins, right? And we know that vitamins is required in micrograms and milligrams, not in kgs. So eating it in kgs is not giving you more nutrition because it's going to go out of the system, as I said, by the end of the day. It doesn't get absorbed more than what is required. So you're wasting good money by eating all those expensive foods. You certainly need a bowl of fruit is enough for all of us once a day. The other beneficial effect of fruit is it gives some fiber. Not a bad idea, especially if you tend to be a little constipated. Not a bad idea. But remember, the amount of the fruit sugar, sucrose, which goes in, and sometimes the amount of fiber that goes in can cause diarrhea, can give you a lot of bloating, a lot of gas. So it can come at a cost of giving you discomfort somewhere else. So eat wisely and don't blindly follow what is done, because this is exactly what happens in the West. Say, oh, I take a whole bowl of salad and I have that for a whole meal. That's all right for the Westerners who eat otherwise a whole bowl of beef or meat and nothing else. So they're compensating for that by eating some fiber. But the Indian food, typical Indian food, is already rich in fiber. So we just need to add a little more and not a whole bowl full of salad or fruit. That's my little gyan that I think is important.
Great. And speaking of diet, doctor, I think it was Saku who had a question about intermittent fasting. Do you recommend it? And going vegan and all of those things, do you recommend it?
I don't think I would favor any of those. For one, because I can't stay hungry. So anyone who decides to eat for the first 8 hours and stay hungry for the next 12 hours or 14 hours, I don't think is doing good. I'm aware that there is some amount of science behind this, no doubt about it. If you're doing it only for feeling good and you can handle it, I have no fight against them. But those people who go vegan and things like that, I don't think is absolutely essential. I mean, if you've got strong feelings about you don't want to touch dairy for some reason, religious reasons and things like that, fine. But I think ultimately you have to balance it out over your nutritional needs. If your nutritional needs are fulfilled and you're not suffering from any kind of malnutrition because of those diets, fine. But certainly if you're a diabetic and want to go and do one of those keto diets or intermittent fasting, I don't think that's a good idea. If you have a liver disease, you have a bad cardiac disease, going and doing that is not a great idea.
Okay.
But by and large, I'm not a big fan of any of these diets because I don't think they have been really tested scientifically. It's word of mouth. Someone just says it's been going on, but good scientific studies have not been done to really support it.
Okay. Mavis has a couple of questions. She says, how can severe constipation be treated? I'm assuming naturally treated or medically treated. And in addition to that, she says, if you can throw some light on a leaky gut.
Leaky gut, okay, good. Now, as far as constipation is concerned, we have three groups of patients when we see constipation. Some basically have a problem with their diet. They're not eating, a kind of a balanced diet, very little fiber, and they get constipated. They go out traveling, dietary changes, constipation. So those are the easy ones to manage. In the next group, we have again two groups. One is the chronically constipated, and there they have a slow motility. That is, the colonic function or the pushing function of the colon is very slow. And for that, there may be many causes for it. Some of it may be sort of unknown to us as to what is causing. But a lot of times you can have disease like diabetes, you can disease like thyroid, you can have high calcium, you can have a lot of drugs that we take, or disease like Parkinson's, or people who are got seizure disorders or who are mentally challenged. They tend to have constipation because of these disorders. And we have a plethora of drugs available to treat them effectively. But what is not well known is a group of people, almost 20 to 25% of those with chronic constipation have a disorder at the lower end. At the lower end, we need a series of coordinated steps for us to pass out our motion. I use the analogy of a toothpaste. How do you squeeze out toothpaste onto your brush? You remove the cap and then you squeeze the tube. Just imagine you can't remove the cap and you keep pressing the tube. Nothing is going to come out. And this is exactly what happens in patients with what we call a disallergic defecation, or an incoordinated problem of defecation, where the lower end seems to remain closed even when it's supposed to open. When the upper part squeezes, the lower end is supposed to open for the stool to come out, and this doesn't happen. And unfortunately, no drug actually can treat this. No drug. So you can try all the drugs in the world. The only thing for this is what we do, which is called biofeedback therapy, where we teach them certain exercises and breathing techniques and abdominal contraction techniques, which help them be able to sort of pass out these motions. And the success rates are pretty good, almost about 80%. And these are typically patients who say, Doc, I get an urge, I want to pass motions, but I go there, nothing happens. I keep sitting there for long periods of time. As against those who have a motility problem, they say, Doc, I don't get an urge, 2, 3 days, 4 days, I don't get an urge. That is a different group from these who get an urge, but just can't seem to get it out. So constipation can be well treated once you analyze what the cause is and, sort of make an appropriate diagnosis and then use medication or whatever it is. But remember, in the elderly, please do not ignore constipation, because apart from a bad quality of life, cancer colon is an important cause of constipation in the elderly. So please, if your constipation goes beyond a week, consult your doctor and try and figure out what is happening. There's another question which had...
yeah, so the other thing she asked for was a leaky gut. Did you cover that?
Okay. Very good. Now, leaky gut, we know that the gut is sort of has got these cells which are very in close opposition to each other. And we believe that a lot of our autoimmune diseases are because of a leaky gut. That means what is in the gut tends to go inside the body and create various kind of infections. And for example, all of you, most of you here are women, I see, and all of you have rare children, and you make sure that you give your baby only breast milk up to a certain age, then you have weaning foods. And typically no one starts eggs till they are a year and a half old. Why is this? Because in a baby, the gut is leaky right in the beginning. So if you use these foreign proteins like eggs, they can go into the system and trigger various kind of allergic reactions. So we believe that a leaky gut can cause these kind of reactions, and we believe a lot of diseases like rheumatoid arthritis, SLE, and so on and so forth are because of leaky guts. So that's a hypothesis, but I don't think we have too many medications to seal the leaky gut. We try and treat the basic disease if possible.
Okay, thank you, doctor. Sushil Kumar says, what is easy to digest for a 70-plus-year-old person? The uncooked food or cooked food? He had tried uncooked food for 6 months at 25 plus, but now at 70 plus, he's trying to do the same, and he's on 75% uncooked food. And in the same light, doctor, do you recommend white rice over red rice and things like that?
Okay, good question. Now remember, in an older person, there are several factors. It's not just that our hair looks gray or our bones grow weak or our muscles become weaker. It's even our gut ages. And we find that we are not able to handle food, the same food that we were handling at 25 or 30 or even 50 becomes a challenge at 70. So right from whether you have teeth or you're using dentures, that itself decides what you're going to be able to eat. And we have a lot of elderly patients who have a problem of poor salivation. So they have disorders of being difficulty in swallowing. So they find hard food is difficult to swallow. They have dentures or some deficiencies which makes a lot of oral burning, like zinc deficiency, B12 deficiency can cause burning. Then you have a problem, as I said, with swallowing, and then finally absorbing these foods. So I think there are many, many mechanisms that come into play in the elderly, which makes, handling food a challenge. So you have to decide what is best for yourself with the trial and error method. But I would believe that it's best with cooked food, soft food, less spicy food, I think are easier handled than the more dry or very spicy or uncooked food. Now, the last question was red rice versus white rice. Now, this is a concept that I want you to understand about healthy food. Now, healthy food, healthy lifestyles are really what we want the 20-year-olds and 30-year-olds to follow. Because in them, it's going to make a difference, because that impact is going to occur not over 1 year or 2 years. It's going to occur over several years and decades. For example, you're treating a high cholesterol or high triglyceride, very important in 30, 40, 50-year-olds. But in a 70-year-old, what are you trying to do? You're trying to prevent a heart attack at the age of 95. So the same analogy for red rice and white rice. I mean, it doesn't make a difference, big difference. It may make a very small difference. If you like your white rice, please go ahead and take it. There's no need to change to a red rice. If you're comfortable eating the red rice, fine. But there's no need to change, because the gain that you're going to get in terms of, less stroke, less heart attack, less cholesterol is minuscule, right?
Great. That, I hope, answers your question, Mangla Kumari. Someone with a number AA75207 says, for gallbladder stones, is surgery the only way out, or do we have proper medication?
Right. The answer is there are no drugs for gallbladder stones by and large. By and large. So surgery is the only answer, but surgery is not required for most people. Right? Why? Now, there are 3 questions that I ask myself when I have a patient with gallbladder stones. One is, does he have a stone? So you need to look at the ultrasound and say, yes, it's really there, or is it a polyp, or is it something else? 2, does he have symptoms? Right? And 3, most important is, does he have symptoms due to the gallbladder stones? For example, if he's burping a little, or he's got, heartburn, and he's got gallstones, we know that those symptoms are not due to the gallstones. Right? So those known, why I'm emphasizing this is that in the older population, and when I say older, I'm not talking of 70 necessarily, but even beyond 40, 45, we don't recommend surgery unless you have symptoms. So if someone has symptomatic gallbladder stones above the age of 40, 45, surgery is the only answer. Because the chances that the pain will recur and he'll get complications. If he does not have symptoms, then the chances are he will get symptoms only 7% of the time. Or if you put it the other way around, there's a 93% chance that he'll never get symptoms, and so he doesn't need surgery. So only if you have symptoms do you need surgery in gallbladder stones. The exceptions are if you have a child, because a child has got under 60, 70 years to go, likely to get into problems. If you have a young lady who's planning a pregnancy, because we know that in pregnancy, gallbladder stones can cause a lot of problems and can be quite a mess, both for the baby as well as the mother. Or people who are, getting a, say, a liver transplant or a kidney transplant or something else, or someone who's undergoing bariatric surgery. So there are a few exceptions to that, that we operate even when they have no symptoms. Otherwise, for the adult 45 plus, unless you have symptoms, no need of surgery.
Okay, great. Could you shed some light on acid reflux, doctor? Dr. Rama Chandran would like to ask this question.
Okay. Now, acid reflux is basically what the laypersons would say acidity, hyperacidity, and so on. But typical symptoms are heartburn, and say, I feel something coming up right into my throat, some sour liquid comes up, that is acid reflux. Some patients do not have these classical symptoms and just come to us with a little change in their voice or a chronic cough. That also can be because of acid reflux. And what is acid reflux? Acid reflux is acid from the stomach coming up in the wrong place. It's not necessarily extra acid, no. It is just a normal acid going up into the wrong place and causing symptoms. And what predisposes to acid reflux, most important, is obesity. 2 is bad food timings, eat irregular timings. A lot of coffee is bad, alcohol is bad, smoking is bad, irregular food habits, I said, very oily food. You know, a typical disaster, smoking, glass of, whiskey, obese, and eating a lot of fried snacks. I think that's a classical recipe for disaster as far as reflux is concerned. But yes, you can have a lot of reflux even in pregnancy, because of its hormonal changes, then you put on a lot of weight and your tummy becomes big. That pushes the acid up. So that can also cause acid reflux. So several causes, but remember, lifestyle changes, very important. Weight reduction, very important. And regular food timings, very important. This fashion that we have picked up from the West of having a lot of beer, a lot of black coffee, 5 cups a day, 6 cups a day, all these are bad for reflux. I think we need to give that up.
Okay. Panatpur Murthy says if he eats oily things, he has severe stomach upsets. And even if he doesn't eat outside, he has terrible stomach upsets along with loose stools and vomiting. So basically a very sensitive stomach.
Correct. See, this can occur because of many causes. Now, you can have a 25-year-old chap who goes and, lands up in a wedding buffet and, hogs like hell. Right? And then it's not surprising that the next day he has a diarrhea or, upset stomach. That is basically gluttony. You've overloaded your system, you can get into problems. But for a senior citizen, when this happens, quite often we find that obviously they are sensible, they know what to eat. But this usually happens if you have either an infection in your gut or even a B12 deficiency. Vitamin B12 deficiency can give you this and make your system very sensitive. So I would look for simple things. We pick up patients with diabetes with these kind of symptoms as well. So I think maybe some simple tests may be in order to address the problem.
All right. Now there are questions.
So just 1 minute, Deepti.
Sure.
So remember, it's the same symptom. In different age groups, one tends to look at it differently. So the causes or the solutions would be different depending on the age group. So if it's a very young, if it's a child, I may say it may be food allergy. If it's a teenager or a young man, I may say gluttony. But in a senior citizen, it may be something else. So I think that is a kind of perspective that we need to have as doctors to be able to understand and individualize each one's problems and look at it appropriately.
Excellent. So there are a couple of people who've asked questions regarding natural remedies like turmeric water, dry fruits, ginger, cardamom. What's your take on natural remedies?
Natural remedies are excellent. No doubt about it. That I would encourage everyone to try their natural remedies as first-line therapy. For if something is going wrong for 2-3 days, try whatever you want at home. Absolutely no problem. But you can't overdo it. and you can't persist with it even if it's not delivering the results, right? For example, now in COVID times, now there's so much talk about immune boosters and things like that. So everyone putting, a handful of haldi and so much of cinnamon and so much of ginger and things like that, that half of them are just coming to me with symptoms of hyperacidity. The doc, I've been having, then say, how much of ginger thing I take? Oh, his doctor, every day in the morning I take this, afternoon I take this, evening I take this. So remember, why are they good? Some of it has scientific reasoning. Some of it are just because they are minor irritants. Why do we add, say, hing or asafoetida to our cooking? Is because it's a minor irritant of the gut. So it tends to get rid of the gas. So similarly, our condiments that we use have a similar function. They are supposed to be irritants, and we add a lot of these irritants. Obviously, you're going to have a lot of irritation going on in the gut. So try it, but don't overdo it, and don't say that the more I add, the more immunity I'm going to get. That's simply not true. So this is a myth that these are great immunity boosters. They add that 2%, 3% overall benefit, but not that they make your immunity from being, terrible to terrific. No, it doesn't act that way.
Okay. Hidayat requests you to explain the reasons for bloating and feeling gas without any symptoms of acidity.
Yeah. So remember that why do we get gas? Now we have gas in three forms that we put it. One is where we have people who say, I keep burping a lot. I keep bringing out gas. And that group is basically swallowed air. Air does not get produced in the stomach. Stomach, when I say, I'm talking the anatomical stomach, not the abdomen. In the intestine, it does get produced, but in the stomach, what we belch out, 90% plus is swallowed air. So we swallow air as we are eating. We keep talking a lot as we are eating. We drink a lot of water as we are eating, or we are subconsciously swallowing when we are anxious or nervous. All you have to do is just, look outside and, waiting room where there are interviews going on, and everyone is doing that. So that is a subconscious thing that happens. And a lot of us swallow air. And that is the chief cause of burping. Sometimes hyperacidity causes burping because we swallow saliva to overcome that. So that is one group. Then there are groups where your intestine movements are slow, sluggish, because it depends on what you eat. If you eat in a very sort of fatty meal, the system slows down to allow you more time to digest. And so you feel bloated and gassy. 3 is you can have a poor bowel function. You may be constipated. That may give you a bloated feeling. But remember, you may actually be having a condition called malabsorption or maldigestion, where it may be a pancreatic disease or a small intestinal disease, which may not allow all the food that you eat to get digested. And that can give you a lot of bloating and gas. And that typically tends to be passed down from below. And this is, again, people who drink a lot of milk tend to have this lot of bloating, lot of gas. And these are simple causes which can be sort of easily treated.
So does this also cause slow digestion? Usha Ramnath says she doesn't find herself feeling hungry too often. So she wants some advice on slow digestion and how to tackle it.
At this age group, I mean, I'm talking of 60 plus, I don't know how old Usha is, but 60 plus, I usually look for diabetes and thyroid disease in my population, because very often these are missed and these need to be diagnosed and treated. We also look for B12 deficiency. If these are not there, then we sort of address the constipation or address dietary factors and deal with it. So rule out systemic disease, address constipation, and address dietary factors which may be responsible for the so-called slow digestion.
All right. Doctor, first of all, I want to thank you so much for explaining to us so patiently and with all your analogies. It makes a lot of sense to all of us. I just wanted to check with you. Are you okay to take questions till 7:30? Is that okay with you?
Yeah, till my wife calls me for dinner, I'm fine.
We'll keep you with us all evening. Don't say that. Okay, so I'm moving on to the next question. Bharati Sagar says if you can explain to us a little bit about a gallbladder crashed. Is that a topic you'd like to talk about?
Gallbladder?
Crashed. What does gallbladder crashed mean?
Crash.
Yes.
I don't know what it means. You'll have to
You
be a
know
little more
someone who
specific.
had that in a report, and should they be having boiled food? I'll just paste her question in the chat box.
You just put it at the end of the thing so that.
Yes. Oh, sorry, that's the wrong message. 1 second. It doesn't allow me to copy paste.
Yeah, what does gallbladder crashed mean?
Yeah.
I don't know what it means. I really don't know because see, gallbladder diseases are largely those related stones. 90% are related stones, and I would imagine that it's either the gallbladder has sort of perforated, made a hole, or gangrenous or something like that. I don't know, but unless this she has a different meaning, I don't know.
Okay.
But if someone has a gallbladder disease, is there a dietary restriction? Yes, very oily food tends to cause very vigorous gallbladder contractions, and it tends to sort of trigger pain. So that's something that you would want to avoid. Otherwise, nothing really.
Okay. And speaking of the gallbladder, someone with a Motorola One Power says, due to gangrenous gallbladder, can the liver get affected up to the level of liver cirrhosis?
No. See, the gallbladder perforation, gallbladder stones, etc. A gangrenous gallbladder will not cause that. But sometimes, if you have a gallbladder stone which slips into what we call the bile duct, that can cause, and if it goes unrecognized, which rarely happens, it can cause cirrhosis. But if you ask me how many I've seen in my 38 years of gastroenterology, I think I've seen one. So I think that would be an absolute rarity.
Okay. Bhanu says, how does one develop diverticulitis? Is it related to irregular or wrong eating habits?
Very, very good. I think this is a very important question because it affects a lot of older population. Now, diverticuli are pouches in the intestine, and typically we find this in the large intestine. If I do a colonoscopy in 80-year-olds, I'll find it in 80% of them. Right? If I do it in 30-year-olds, I'll find it in 1%. So as you grow older, you find that the incidence of diverticulosis, which is the presence of these pouches in the large intestine, increases. Now these can have some complications. Some of them can just have a little discomfort in the tummy. Some of them can bleed from them, severe bleed. They can just bleed half a liter to a liter at times. And some of them have infection in that. The stool gets stuck in that little pouch, and that causes infection around, and it causes a small hole, or what we call a microperforation, and that is what is called diverticulitis, and that can have several complications as well. Now, so diverticulitis occurs in patients more frequently if they are taking painkillers, non-steroidal anti-inflammatory drugs like diclofenac and other things that you take for your body pain and back pain, not crocin or paracetamol, but the other groups that you take, brufen and things like that. That's one group. And patients who tend to be constipated more often tend to get complications of diverticulitis as well. So if it occurs more than twice, then there's a major complication, then we operate. Otherwise, by and large, we can manage them without surgery as well. But not more than 2 attacks are permitted before we operate.
So, doctor, a lot of people have written in with personal issues. Would you like to address them, or do you think they should meet with you one-on-one, or how would you like to go about it? Because someone here says they have gastric problems when they eat certain foods like lobia and green gram and things like that. Would
Yeah,
you like to address?
just to put it in a kind of broader perspective, for, so that everyone kind of benefits from it, because obviously each one has got its individual thing that we have to address on, as you rightly said, on a one-to-one basis. Uh, Food-related issues can be several. At one extreme, it can be a food allergy, not so common in adults or older people, more common in children. And typically it occurs with seafoods, egg, dairy, and so on. But yes, some of us may tolerate certain vegetables well, and your spouse may not tolerate it well. She may not like it, or she may actually develop an allergy, or she may have a lot of symptoms. So I wouldn't break my head in trying to find out why that is happening. I'll say, okay, if you have a problem with Loki and Tinder, give it up, eat something else. Right? So that's the way I would look at it. I wouldn't try to dwell and say, what is the mechanism? Why is it happening? Is that a disease causing it? Very unlikely. So if something doesn't, so it's as simple as saying, I like tea, I don't like coffee. So are you going to do a test on me and find out why I don't like coffee? I'll say, okay, you like tea, you take tea, I'll give you tea. So that's how it is going to be.
I guess just being a little more in tune with your body would really help.
Correct.
Okay. Sriram Iyengar is struggling with constipation. He said he's been a chronic patient of severe constipation. He passes hard stools by applying pressure. No natural medicines like Ayurveda are helping. If you can suggest any long-term solution, it will be really helpful.
As I said, we need to sit down and work out whether he is basically a slow transit constipation, that's a motility problem. Is there a systemic disease causing it? Is there a drug that is responsible for it? Or is that the other end of the spectrum, that is the closed toothpaste tube? So that will decide how we're going to treat him. So we'll have to sit down and chat one-on-one.
Okay, great. So Jesse here says, what is the difference between kefir and curd with regard to probiotic benefit?
I'm sorry, I didn't get that.
Kefir and curd. I just pasted it there. With regard to probiotic, I think kefir is something she uses for as a probiotic. Have you heard of it?
I don't know. Kefir, okay. Kefir and curd, I don't know. I'm not very familiar with this term. I've heard of it. I honestly don't know.
Can I say, Deepti?
Sure, go ahead.
Yeah, kefir is made out of the kefir grains, and it has got supposedly better probiotic benefits than the curds. And these are living, it's a culture. Actually, it's a culture. And then the curd comes out of that. It's supposedly better than curd, but I just wanted your opinion on that.
See, as I said, as a medical personnel, we restrict the use of probiotic to drugs or commercially available drugs, not what is sold over the counter. So I guess if you think it's beneficial and it can replace curd in your day-to-day, I think it's not a bad idea to think. But to see, is it scientifically proven? See, the big problem of probiotics, let me just spend a minute on this, is what we say probiotics are good. Fine, perfect. We want to populate the intestine with good bacteria. Perfect. But what happens when you give the big good bacteria inside? How much of them get destroyed in the stomach? How much of them reach the intestine? How long do they stay in the intestine? Perhaps they just stay there for a few hours or a day or two. They don't stay longer than that. How much needs to be given? What combination needs to be given? How is it to be packaged? Now, these are the challenges that the people who are, marketing it as a drug are grappling with. So it's easy to put something in a cup and say this is a probiotic, but it's not scientifically correct because it doesn't mean anything. And if your science say that probiotic is good for this disease, probiotic is good for that disease, we still don't have studies. even after being involved with probiotics for 15 years, we still do not have more than 2 conditions where we can recommend probiotics as a medication. We can't, because we just don't have evidence for that. We don't know what works. So probiotics is a great concept, but not available for real-time use. I mean, on a scientific, at a scientific platform as yet. But whatever if you believe that your curd is good for you, your kefir is good for you, great. Please go ahead and use it.
Thank you, doctor.
I don't know. This probiotic seems like a spam thing or like a marketing gimmick for a lot of youngsters. A lot of them, even in our family circles, the children also say, "Mom, why don't you have probiotic curds? Why you want to have regular curds?" I think it's become like a fad.
Absolutely. Yakult is another thing.
Yeah.
I mean, grossly sort of misuse or abuse or whatever you want to tell it. If you want to know what it is, if you know what it is, then perhaps you'll never use it again.
Wow.
Yeah.
So I think, like you said, just stick with natural homemade curd where you trust the ingredients yourself.
And just to conclude, I make this at home every day. It's like curd, but then it has supposedly it has less sugar than the curd. So that's where I make it every day at home.
You don't put any sugar in the curds generally.
Okay, let's go to the next one.
Okay, doctor, would you have an alternative to endoscopy? Would you recommend an alternative to endoscopy?
Yeah. I mean, there are ways. If you don't do an endoscopy. There are now capsule endoscopies available. You swallow something, keeps taking pictures. See, the problem with capsule endoscopy, it is 10 times more expensive than an endoscopy. And a gastroscopy costs typically around 3,000 or 4,000 rupees. A capsule endoscopy will cost you 30,000 rupees, right? When I do an endoscopy, I can take a biopsy. If something is bleeding, I can treat it. I can do a lot of things with it. And hence, at the moment, I think endoscopies has far more advantages over the other capsule endoscopy or other relatively non-invasive modalities. So the simple answer is yes, but it doesn't do half the things what you can do with an endoscope. If people are worried about endoscopy because they fear that there's a lot of discomfort and pain, but I think it's important that most patients who undergo endoscopy are sedated or need to be sedated, certainly. And so the overall experience is quite positive. And a lot of my patients tell me after the endoscopy, they ask me, when are you going to do the endoscopy? They said, I never realized that you finished procedure. Because sedation does make that big difference. So insist on sedation, and I'm sure your endoscopy can be a more pleasant experience than is sort of generally talked about on the net and other things.
Excellent.
Capsule endoscopy is still not there. It's available, but it doesn't give us all the information that we need.
Okay. 2 last questions, doctor. It's 7:27. I don't want to keep you beyond 7:30. Someone here asked about symptoms of a leaky gut. What are the symptoms that one should look out for?
No, see, leaky gut is a concept. It's not that it is one disease, right? So a leaky gut leads to many diseases, right? So the origin of, say, celiac disease is possibly a leaky gut very early in infancy, early weaning. If you start a child at the age of 3 months, 4 months, 5 months with wheat, if he has a leaky gut, that will sensitize the body to those proteins. If you start an infant with egg, it may sensitize it and give an egg allergy. So leaky guts lead to various autoimmune disease. It's not a disease by itself.
Okay. And Subhashini here wanted to check if you could speak a little about osteoporosis. Is that an area you'd like to talk about?
Osteoporosis is basically a disease of the bones. Now, bones have 2 kinds of diseases. One is osteopenia, where there's less bone formation, and osteoporosis, where the rate of destruction of the bone exceeds that of the formation. So one, you can have just a little calcium deficiency, or a vitamin D deficiency, which leads to osteopenia or soft bones. Because osteoporosis is where the rate of destruction is more, and this usually occurs in people who are older. It's a natural process as we occur older. Especially women are more prone to it because their hormone levels come down after menopause, and a post-menopausal state, they become more prone to it, as against men who have some amount of testosterone still going around even when they are 60, 70, and they are relatively protected from osteoporosis. People who are extremely skinny, very thin-built individuals are more prone to osteoporosis. People who are immobile, not active, just lying in bed for various reasons are more prone to osteoporosis. So osteoporosis is a serious condition because you can get bone fractures without a fall, or a trivial fall can lead to a major fracture. And that is why you're worried, and it can occur in the hip bone, it can occur in the spine. And hence, we recommend that as you age, you check for osteoporosis and if necessary, correct it so that your fracture risk comes down.
All right. Okay, doctor. Before we end this session, just a quick question. How does one get in touch with you if they'd like? Because there are quite a few more questions. Would you like for me to email you, or how do you recommend we go about it?
Either way is fine. You can email it to me if I can answer the thing. But the other way, if you want to see me, I can understand in COVID times, people will be scared to come to hospital. But if you can come, let me tell you that the risk of picking up COVID in a hospital is extremely small. It's about 1% from what statistics tell us. And at 65, I go to hospital 6 days a week and work 8 hours a day. And so it's not that bad. But yes, we have an option of, you can do a teleconsult on the app from the Astor Hospital, and we can chat one-on-one and resolve some issues. If you need to come and see me for some reason, if I can't handle it on the virtual platform, then you can drop in the hospital and see me at some convenient time.
Excellent, doctor. Thank you so much for, again, so patiently taking all the questions. I'm just going to take you off spotlight so you can see everybody. Everyone, can we have a huge round of applause for Dr. Naresh Bhatt for all the time that he spent and was so patiently and so sweetly explaining everything to us. I want to definitely thank Nalini Shashidhar, who's a member of Silver Surfers, for introducing you to us and having you facilitate this.
Nalini is an old friend of about 30 years now.
Wow.
So we're growing old together.
Lovely. You should join the Silver Surfers Club and grow old with us. And to
Not with you, you're very young. I can see the rest of them.
I'm an old soul, let me put it that way. And to Rama, of course, for moderating this session at such short notice. Thank you so much, Rama.
My pleasure, Aditi. Thank you. And it was a pleasure to have Dr. Naresh Bhatt talk to us here.
Thank you so much.
And everybody, I hope I did some justice to all of your questions. I know there are still a few more, but they're just coming in. But thank you so much. I hope you enjoyed this session. And we'll see you at our next webinar. Thank you again, Doctor.
Bye-bye.
Good night, everyone. Bye.
Good night. Bye-bye.
Good night. Bye-bye. She's the founder.
For those of you asking how you can get information about our upcoming webinars, it will be listed on our website. That's www.thesilversurfersclub.in. I'll just post it in the chat window for you.
Was that for me?
That's for someone who put up a question.
Okay.
All right, guys, with that, we come to the end of the session. Thank you.
It was wonderful.
Saturday evening.
Thank you, Dipti.
Enjoy your weekend.
Thank you so much, Dipti.
Thank you. Bye-bye.
Thank you.
Bye. Bye.
See you soon. Bye-bye.
Bye. Bye, Dipti. Bye, everybody. Good evening.
I am leaving.
Thank you and bye. Good night.
Good night.